Welcome to McTox Curriculum. This is brought to you in collaboration with Western University, the University of British Columbia, and McMaster University. This presentation is part of McTox Curriculum, built for residents and fellows from PGY 1 to 5. This presentation, brought to you by Vanderbaugh, is covering antimalarial treatment toxicity. After this module, learners will have a good understanding and approach to antimalarials and their toxicity. They will also be able to discuss what treatments are available in the event of a poisoning. Many antimicrobial drugs can be used as antimalarial treatment. Some of them are specific and others are more general, including quinine-related medications and other drugs that have antimalarial effect, including antifolate drugs and macrolide antibiotics. This presentation will be focused on the quinine-like antimalarial drugs. Two very similar drugs that are worth mentioning are quinine, which is an antimalarial treatment, and quinidine, which is a class 1A antidysrhythmic drug. They are optical isomers and share common antimalarial and prodysrhythmic effects. Quinine and quinidine toxicity present similarly and are treated also in a similar fashion. For a detailed discussion on antidysrhythmic toxicity, please refer to video 4.3 in the decontamination theme. Jumping right into our first case, we have a 52-year-old man with a syncopal episode a few days after feeling unwell with tinnitus and blurring of his vision. He recently returned from traveling abroad, where he passed through several regions where he was required to take malaria prophylaxis. His history is significant for hypertension and a type of inherited long QT syndrome called Romano-Ward. He's taking ASA and an ACE inhibitor. On exam, his vitals, including cap sugar, are within normal limits, and he has a normal physical exam. What will be your approach towards this patient? Remember back to our previously discussed toxicologist approach. Let's answer those questions again. He presented with syncope, visual and auditory changes, without a lot of abnormalities on exam. This could be tox-related, given the recent use of malaria prophylaxis, but we need to rule out other serious diagnoses like stroke, dysrhythmias, and other medication effects. So we will proceed with a tox workup, including a trope, ECG, and CT head. His blood work comes back all normal, but you pay close attention to the ECG and find his QTC prolongation has gotten worse. Taking a closer look into quinine toxicity, it causes both cardiac and extracardiac manifestations. Extracardiac symptoms involve GI upset, auditory toxicity causing tinnitus and hearing loss, as well as retinal toxicity and decreased vision. Cardiac effects are significant for its sodium, potassium, and alpha-blocking properties. The mainstays of treatment in this case are obviously discontinuing the medication, continuous cardiac monitoring, and serial ECGs given the high risk of rhythm disturbances. During this time, the physician should also make sure that the patient isn't taking any other medications that can prolong the repolarization phase. Luckily, most of the symptoms caused by quinine are self-resolving and do not require any specific intervention. Moving to another case, we have a 39-year-old female who presents to the ED with a seizure and signs of shock. This was following a known overdose of her hydroxychloroquine about 3 hours before. Clinically, she is unstable, both bradycardic and hypotensive, with a decreased LOC. As you can see, we are going to use the toxicologist approach because this time it's a known toxin ingestion. Let's go step by step. Starting with patient stabilization. She is hypotensive and not protecting her airway, so she needs fluid resuscitation, possibly pressors to support her blood pressure, along with urgent airway control. When the patient is stable, you can quickly gather a focused history from the patient, family, EMS, or police personnel. In addition, reviewing the patient's chart from previous admissions or attempts may help you facilitate decision-making in some cases and should be done during this stage. Our next question is, do we need to decontaminate this patient? After stabilization and airway control, we can give her 1 gram per kilo of activated charcoal through a confirmed OG tube. This patient is symptomatic already, and it's been more than 3 hours after ingestion, so decontamination is controversial. However, if you know that multi-dose activated charcoal can reduce the hydroxychloroquine half-life and the patient has a confirmed airway, then starting activated charcoal will make sense. A routine toxicologic workup should include the following. The general treatment for the management of a hydroxychloroquine poisoning includes IV fluids, and inotrope suppressors is needed for hemodynamic support. Benzos are the treatment of choice for any seizures, and as in all sodium channel blocking drug overdoses, bicarb can be given for widening of the QRS. Drug elimination is enhanced with multi-dose activated charcoal, which should be considered especially in large overdoses where the patient's airway is already secured. Questions for this module are the following. 1. List 3 causes of syncope in a patient with quinine toxicity. 2. What are the treatment options for quinine-induced torsades de pointe? And 3. What is the risk association with treating QRS prolongation with 3% normal saline and quinine toxicity? That's everything. Thanks for watching.